ladies and gentlemen, this is Dr. Helge Alexy from the cardio team, and I welcome you to the next cardiology case and quiz we today present to you. We hope you enjoyed the last cases we showed you, and we also hope you will get some interesting information out of this case, and let us discuss the different approaches one might have in these cases in the comment section below. Well, let's get started with the first slide. We called this case "Why is the pump function getting worse and worse?" And it's about a 50-year-old male who has coronary heart disease and STEMI in the past, with even the need of coronary artery bypass graft surgery. He complains about decreasing personal resilience, had a NYHA 2 before, is on NYHA 3 now, and has had a LVEF of 53% and is on 40% now. Because of this bad echo performance with the decreased LVEF, he got another cath performed, and it showed no progression of the known coronary heart disease. The bypasses were open, and the admission to us was then for further medical optimization. The TTE we then performed showed a very bad echo quality because of adipositas per magna of the patient. The EF was suspected to be highly decreased now, and a hyperdense structure seen in the apex of the LV. Because we couldn't confirm these findings because of the bad echo quality in the TTE, we decided to perform a TEE at the patient. So the next loop I'll show you is the TEE of the patient. This loop shows the 4-chamber view, and especially concentrated on the left ventricle and left atrium. We see the mitral valve opening and closing regularly, and we see I think in this loop you already get a clue of the LVEF that seems not to be normal. We also saw this structure in the LV apex. We also saw this in the TTE, but here it's very clearly this structure doesn't belong here, and it's a very hyperdense structure. This is a view of a different angle, about 120 degrees. We also see the left ventricular function is maybe not normal, and the apex shows this structure again. In this loop we zoomed in on the LV apex to see this structure again, and we also see that it's floating in the LV apex, so it's highly suspicious of a LV apex clot with about 1.2 and 1.5 centimeters. So this is the first quiz question for you. What do you think is the patient's EF? Is it A, normal? Is it B, 51 to 41%? Is it 40 to 30%? Is it 29 to 15%? Or is it below 15%? Well, take your time to choose, and then I'll give you the answer. Okay, I think you all made your choices, and I think we all agree that the LVEF is not normal. And when we performed the Simpson method to measure the EF, we came to a result of 35%. So it was noticed that the heart rate was about 118 beats per minute constantly since admission. Uptitrating beta blockers and initiating of ivabradine were discussed to get the heart rate down. Well, this is the ECG of the patient. First of all, we might look on the chest wall leads, and here you will see that there's a very low R wave, and this very low progression of the R wave here we see in the chest leads is due to the ischemia the patient had with his STEMI some years before, and because of this he got the CABG operation performed. So this is the old ischemia. What do you think is the underlying rhythm here? Do you see P waves? Well, I think we see P waves here, especially in V1. The P waves are very clearly seen here. It's a little bit with artifacts, the ECG, done with artifacts thoroughly, but I think it will do for what we want to see. We also see P waves in the extremity leads. Maybe here, P waves, and here the P waves. Okay, so might be a sinus rhythm of 118 beats per minute. Now we are concentrating on the extremity leads. Especially take a look on lead 1, please. After this ECG, we rearranged the leads a little bit and performed another ECG. And now especially look on lead 1, please. This here is an artifact. There should be R waves, but in this moment the patient moved and one lead had no contact for some seconds, and this is this little pause here that shouldn't be there. There was no pause. This is an artifact. We see some VES, ventricular extrasystoles, here and here, but especially please have a look on lead 1 here, and especially the P waves. Is something different here. And now I show you the last lead 1 of the last ECG with this one. And this is the lead 1 combined, the two ECGs combined. The first one is the lead 1 with a normal arrangement of the extremity leads, and the second one is the ECG with a rearranged, and I'll tell you how we rearranged it, with a rearranged extremity leads here. So what is the difference? What does these two ECGs tell us, and what benefit do we have when we rearrange the extremity leads and get this slightly atypical lead 1? Well, especially please have a look on the P waves. In the normal arrangement of the leads in lead 1 we see P waves here. This is a negative T wave, and here we have a negative P wave. P wave, P, P. And then we rearranged the leads, and now we see upright P waves here and here. Here, here, here. But there is also one wave here, directly in the QRS complex. And this is also a P wave, now appearing in the lead 1 with a rearranged extremity leads. This P wave here in the QRS complex only appears when you perform a special lead arrangement, a special ECG. And this is the Lewis leads. The Lewis leads are slightly different arranged extremity leads, and I'll show you how. One might now diagnose as an atrial flutter. Atrial flutter, P wave here, P wave here, P wave here, P wave here. So 2 to 1 atrial flutter. 2 to 1 atrial flutter. And because we have a ventricular rate of 118 beats per minute, we have twice the atrial rate. So the atria are at a rate of about 236. Our working hypothesis is now a 2 to 1 atrial flutter. So you have to arrange the extremity leads to gain the loose leads. Normally the extremity leads, you have the right arm, left leg and right leg lead, and to gain the loose leads you have to rearrange these leads. And the right arm lead, you are switching to a position to the jugulum at the apex of the sternum. The left arm lead is switched parasternal to the right at the ICR 4th ICR, and the left leg lead is switched to the position of the right rib bow. So if you have rearranged these three leads, you get the Lewis lead, and the Lewis lead is especially the lead 1. You perform a normal ECG afterwards, and when you rearranged these leads, you look at lead 1, and this is the Lewis lead. And the Lewis lead has the advantage that the vector is going directly through the atrium, and therefore it has its focus on the potentials of the atrium and the depolarization there. So if you are unsure if there are P waves in your ECG, or to distinguish P waves from different waves in the ECG, you can perform the Lewis lead to get a closer look on this topic. And especially to distinguish a normal sinus rhythm and atrial flutter. You can also rearrange your leads to the Lewis lead, because there you can see P waves that normally hide into the QRS complex or the T waves, and you normally won't see them there. But if you have a Lewis lead, the potential of the P wave is that high because it's that focused on the atrium that you even see in a QRS complex or in a T wave these normally hidden P waves. To confirm our work hypothesis, atrial flutter, we decided to administer the patient adenosine IV because we wanted to disturb or block the AV conduction of the atrial flutter to the ventricles. And if this conduction path is blocked for a short period of time, you see the flutter waves in the pauses you create. This is the TEE while we administered adenosine. Here you see the adenosine on the right atrium and flushing to the right ventricle into the heart. And what you will see in the next seconds is that the adenosine takes effect on the conduction system, and the heart rate will decrease, will get lower and slower. And down here you see the ECG that is written on the ultrasound machine, echo machine. And here on the ECG you can see the P waves in this very rudimental ECG on the echo machine. Here you see a P wave directly in front of every QRS complex. And if I run the loop, you will see now the effect on the left ventricle. Here it's getting lower, and down here you see now a couple of P waves in this pauses we create with the adenosine, and these are the flutter waves we will see on the next slide on the normal ECG we performed. So again, the adenosine is flushing from the right atrium, right ventricle, now taking effect on the left ventricle in a couple of seconds with decreased heart rate, and down here we see parallel the flutter waves in the pauses we create in this little AV block, if you will. And this is the ECG. This is what we saw in the parallel written ECG on the TEE. And here we see very good in lead 2, lead 3 and AVF. We see these flutter waves when the conduction is disturbed by the adenosine over the AV node. And this confirms our working hypothesis of atrial flutter 2 to 1 on this patient with a heart rate of 118 beats per minute. So, what would you have done now? My next question to you is, would you have A, performed the electrical cardioversion? Although we had this LV clot confirmed, we already suspected in the TTE and then confirmed in the TE. LV clot or LAA clot or whatever is normally contraindication for performing the cardioversion, because we are afraid of the consequences of the clot leaving the heart and going somewhere else, especially into the brain, and causing an apoplex at the patient. One might have the argument LV function of the patient is already getting worse. He started with 53 before some weeks or month and is now on about 35, and he is symptomatic at the moment. He has decreased personal resilience, and despite the fact I have this LV clot, we have to perform electrical cardioversion to get rid of this high heart rate, and with a normal heart rate the heart has the potential to regenerate and getting a better LV function. Or do you think it's B? We should put the patient 4 weeks on anticoagulation and then repeat TE, and if the clot is gone, then we perform the electrical cardioversion, taking in concern that the LV function might deteriorate and getting worse in this 4 weeks where the patient will have atrial flutter and a heart rate of 118 beats per minute. So what would have been your next step, and what would have been your approach in this case? Please decide, would you have had the approach A or approach B? Okay, now I tell you what we decided to do, and what we did was we put the patient 4 weeks on anticoagulation and then repeat TE. We fear too much the complication of letting loose the clot in the LV apex and the patient getting an apoplex. Of course, in the 4 weeks the LV function won't get better. In fact, we even took in concern that the LV function will getting worse in this time, but hopefully the patient is not getting that symptomatic that he decompensates, and that he will get over this 4 weeks, so that we can then perform electrical cardioversion with disintegrated LV clot. And now I'll show you the TE 4 weeks later. You see the LV function hasn't been bettered. it's even worse than we measured it 4 weeks before, because the heart rate was still on 118 beats per minute, and that of course couldn't better the ejection fraction of the patient. In fact, we measured EF of 30% now, but if you look at the LV apex, the LV apex clot is gone. So with our anticoagulation of rivaroxaban, we disintegrated this clot in the apex. We also don't have LAA clot, and if in the different angle we also don't see the apex clot again. EF 30% now, patient still, of course, still symptomatic. Loss of personal resilience, but only dyspnea near 3, not 4, and he was able to manage to get over this 4 weeks without too much symptoms, and especially not having the need of getting hospitalized in this period of time. Afterwards, we performed the electrical cardioversion as planned of the atrial flutter with a synchronized shock of 120 joule into normal sinus rhythm. And this is the final result, the final TTE in this case. We performed the control 4 weeks after, only with TTE and not performing TEE, because we just wanted to have a clue if the heart function is regenerating. And in fact, the heart rate is much better. The heart rate is about 70 in this loop, and the peristernal short axis view gives us an impression of the EF now, and it indeed regenerated very good. The patient came from 53%, and in this echo loop he has an EF of 50 again, not the normal ejection fraction the patient came from before some months, but much better than the 30% he had the last time just before the cardioversion. And again, this is 4 weeks after the cardioversion. What the patient told us is that he felt the effect of the cardioversion 2 days after the procedure, the electrical cardioversion, when he took a walk outside and had much less dyspnea than he had before. So the personal resilience was bettered a lot, and he is now on NYHA 1 to 2 dyspnea as he was before the atrial flutter took place. What brings us to the conclusion of this case today? So, if in doubt of the atrial rhythm, always think of the Lewis leads. Try to perform these leads in your emergency department, and think again of the arrangement of the extremity leads to have a focus on the atrial potentials and especially the P waves. If you're unsure if there are P waves at all, if it is a sinus rhythm or not, and especially if you think there is a hidden P in the QRS complex or the T wave, try to get a closer look on these aspects of the P wave with the Lewis leads. The next point would be that you're getting suspicious if you have a fixed heart rate over a couple of days or a couple of hours, whatever, of 115 to 150. This is very often a different cause than sinus rhythm, especially if you have no explanation why the patient should have sinus tachycardia. If the patient has no pain, no dyspnea, especially when he is lying in his bed, no suspicion of a pulmonary embolism or something like this, why should the patient have sinus tachycardia? And if you have the suspicion that it is something different, you can perform the Lewis leads and always be suspicious of atrial flutter. Very often in this case, and you have sinus or you have P waves, but are not sure if this is really sinus rhythm, then be suspicious of atrial flutter. It's the most often misdiagnosed arrhythmia in medicine, so very often we have atrial flutter at these heart rates. And the answer of the question I asked you at the beginning of this case, why is the pump function of the patient getting worse and worse, is of course the patient had tachymyopathy. Because the heart rate of this patient was 118 for weeks, even months. The heart had no time to regenerate. If we are going out and on a walk or running, jogging, whatever, cycling, we have a heart rate of about 140, 150, something like this for whatever, how long you are doing this, or your patients are doing this, half an hour, 1 hour and a half, something like this. We have a heart rate of 140, for example. But after this, we are getting back, lying on the couch, regenerating, the heart rate is going down, we have a heart rate of 50, 60, 70, and the heart is getting to rest, has a pause of this tachycardia, and it can regenerate its ATP reserves. But this patient with atrial flutter, 2-to-1 over month, has no time to regenerate his ATP reserves, and the myocardium, the muscle, is getting exhausted, and it's getting stunned at some time. So the heart rate is getting worse and worse in these patients the longer this underlying arrhythmia is misdiagnosed. So it's very important for these patients with a very fast heart rate over weeks and months that you are looking for the underlying cause, and very often it's the 2-to-1 atrial flutter. Tachymyopathy is a very, very often cause of deteriorating pump function over time with patients who have a very elevated heart rate. So we are at the end now. Thank you for your attention. We hope you found this cardiology case educational and interesting. Maybe you learned something from this. And we're very excited on your comments. Would you have done this this procedure exactly as we did, or would you have had a different approach? What are your experiences with the Lewis leads? Would you have confirmed the atrial flutter with adenosine? And well, let us discuss the different approaches one might have in these cases. And stay tuned, we will upload some new videos in the next few weeks. And that's it for now. Here's Dr. Helge, Alexy and the cardio team. Bye bye.